Good morning, everyone. Today's lecture is on pain and analgesia, and I am Dr. M.I. Shuja, lecturer from Department of Pharmacology. Yeah. Okay, we'll move into the lecture. Pain, as you all know, it is an unpleasant experience, and it a kind of people perceive the same threshold of pain in a different manner. So it is solely individual dependent. Some people, if you take an sting bite, some people they don't even care. Some people they cry for whole day. So it depends. Okay, and it's always a personal experience that influenced by psychological and social factors to a varying degree. The pain and nociception are different phenomena. You should know that. Yeah, in your day-to-day life, you might experience pain, and you should, as medical doctor, future doctor, you should learn to respect someone's pain. Then only you can wholeheartedly treat them. This whole lecture is about the drugs which you will be using to treat patients when you become clinically oriented doctor, and which drugs to use on which patient and on what time. So that you are going to learn. The pain pathway, as you all now mastered on that, you have successfully completed physiology. The nociception is there are nociceptors, there are pain receptors in your body. They directly got activated via some mediators, chemicals, injury, or toxin, and then they cause a pain. Pain is a whole process. Imagine you got a injury to your hand. So here there's a cut injury, you got a tissue trauma. Then what will happen is there are peripheral nociceptors in your hand. They are get sensed, then they pass the message via the peripheral nerve to the dorsal root ganglion, and it goes to the spinal cord where they will bind with another, or they will make a synapse with another neuron. We call that second order neuron. This is the place where the synapse occurs. And from the spinal cord, it carries to the, that means the pain impulse, the pain sensation, it carries to the brain via an spinothalamic tract. From there, sometimes, or most of the time, there are descending inhibition for that particular pain, and we call that pain modulatory pathway. This is the naturally happening physiological phenomena in our body. But those pain modulation may not be enough to suppress the pain you are perceiving. So we are using drugs to reduce or suppress the pain. So that means it will reduce the perceiveness of the pain. The way you perceive it, it will be reduced. Then you don't feel pain. Unless you remove the causative agent for that pain, the pain anyhow persists. So you have to treat symptomatically the pain via giving drugs which act on either at this level or the synaptic level or at the brain level. That's the first thing. Then you have to focus on the cause of the pain and you have to treat that or remove that. These are two things you have to do. Treat the symptom, the pain, remove the causative agent. Okay? So this is, you get the cut injury and the peripheral nociceptors are getting activated. So you can use local anesthetic, opioids, NSAIDs, acetaminophen, that is paracetamol, all the drugs, they come and act at this level. Okay? The peripheral nerve root, local anesthetic, NSAIDs, and opioids will act. At the synaptic level, again, local anesthetic, opioid, acetaminophen. In the brain level, you might have opioid, antidepressant, and alpha 2 adrenergic agonist. If you see, even though you are yet to know the names of the analgesic, in almost all the levels, you are using opioid, NSAID. Those are the two prominent categories of painkillers or analgesic drugs. So how do you perceive the pain? The nociceptors are getting activated, then the information transfers to the spinal cord. From there, it goes to the brain. Then, so this again, how in the higher centers, the pain message or the impulse is transferred. And you all know the gate control theory, so we don't waste time on that. So the gate control theory is mainly to modify the pain response and it's via the descending pathways from the brain. So if you look at this is the ascending pain pathway we have seen, and your thalamus, locus coeruleus, and gray matter area, there are neurotransmitters descend and come, and they have an impact or effect at this synaptic level. So if they come and release neurotransmitters, and if they block here, the pain impulse which you are going to perceive may travel through the nerve and it get blocked, so it may not go to the brain, so you don't feel pain. So that is the place where the pain modulation occurs. So there are neurotransmitters, 5-HT, we call serotonin and noradrenaline. They are used in inhibition of pain. And the action is mainly the GABA. I have already told you GABA is a kind of inhibitory one. So The GABA is act on the presynaptic neuron and they reduce, so they reduce the release of glutamate and substance P, so there won't be excitatory phenomena. So these are the chemical mediators which act on the nerve ending level, the peripheral, at the dorsal horn level, that is the first and second order neuron synapses, and the brain level. So these are the chemical mediators. They are naturally found in our body. Okay. So these are for causing pain and reducing pain. So reduce pain, what we have to do? We have to artificially or synthetically give the substances which naturally reduce pain. That's it. So we are going to synthesize naturally found analgesia drugs in your body and we'll give that to patients and we'll treat them. That's what we are going to do. So that's what we are doing. So the analgesic, that is painkillers, they divide into two major categories. One is opioid peptides, we call this opioids, and other things, the drugs which inhibit prostaglandin synthesis. That is mainly the NSAID family, that is non-steroid anti-inflammatory drug family. We look one by one. The opioid analgesic drugs, they classify it into naturally found drugs, that is morphine, codeine. Morphine is extracted from plant. Okay. Then semi-synthetic opioids, diacetylmorphine, heroin. You might know familiar with this. Heroin is just a combination of two morphine. You take two morphine molecules and they are putting a sulfur bond, then heroin. Synthetic opioids, pethidine, methadone, fentanyl, remifentanil, tramadol, and tapentadol. So the mainly used opioids in our clinical setting are to reduce the pain in the ward. These analgesics either help to reduce the pain in the ward setting or there are high-fi analgesic drugs. Those are used in the operation theater, reduce the pain while a surgery goes on. And there are few analgesic drugs which they give in ICU post-operatively or in the pain management center via different routes. In our setting, in the hospital, you heard of morphine, pethidine, tramadol, those in the ward setting. And rarely you may hear fentanyl. Of course, codeine, you know that. Okay? That's, and these are the main opioids you should or you must know. You can't forget it. There are no excuses. So there are endogenous opioid peptides. I told you earlier, there are few opioids which are naturally found in your body, like endorphins, enkephalins, dynorphins. They are usually released by body in the stressful conditions and during pain. So it will reduce the pain. So there are synthetic derivatives and these are major subdivision: phenylpiperidine, diphenylhepatine, benzomorphin, and phenylephrine. Under that, there are different drugs. So morphine is under the group of phenylephrine. Pethidine, phenylpiperidine. So like that, you should have an idea. It may be asked at true false MCQ because we are supposed to know the basic classification of the analgesic drug. Then these analgesic drugs, mainly the opioids, now we are looking at the opioid, they go and bind because opioid is the ligand, so it goes and bind with the opioid receptors. Then it will activate that, then it will reduce the pain. Opioid receptors in this pathway, that means the ascending and descending pathway of the pain, they release neurotransmitters like serotonin and noradrenaline. Those are inhibitory neurotransmitters of pain. So they will reduce the pain. Opioid receptors found in the brainstem, they regulate breathing as well. When you give more opioids, the breathing reduce. Like that, they modulate. So the major concern is opioid overdose, and people become addicted to opioid drugs. We will look that later. So there are 5 opioid receptor types. If you are reading a book and that book mentions 4 types of receptors, then you have to find the next or latest edition of that book. Because earlier it was 3, then they found the 4th one. Nowadays there are 5 opioid receptors. The major ones are mu receptors, kappa receptors, and delta receptors. But of course, we have nociception receptors and zeta receptors. And opioid depends on their potency, efficacy, or intrinsic activity and affinity. We are going to divide those into agonist, weak agonist, mixed agonist, antagonist, and antagonist. Agonist, weak agonist, antagonist, we have covered in your pharmacodynamics lecture series. And you should know examples of each of that category. As you are new to the term mixed agonist and antagonist, I am going to explain that to you. So, mixed agonist and antagonist, as the name says, it has agonist and antagonist activity. How? Because you have 5 categories of opioid receptors in your body. Main 3 receptors are mu, kappa, and delta. So this drug, like mixed agonist antagonist drug, is pentazocine and buprenorphine. So this pentazocine, it goes and acts as an agonist in one kind of receptor, like mu receptor, it acts as an agonist. At the kappa receptor, it acts as an antagonist. So now you may wonder why we need this kind of drug. You have pure agonist, you have pure antagonist, then why we need this combination of drugs? Because, listen very carefully, Each receptor subtype of the opioid receptors leads to or cause each effect function. Okay. If you don't want a particular function, like dysphoria can be a function, nausea can be a function, suppression of the respiration is a function, or the effect of particular subtype of receptor getting activated. So if you don't need that particular effect, you are going to block that receptor and you will activate other receptors. That is the whole purpose why this category of drug is invented. Mixed agonist antagonist. I hope now you got an idea. So to ease you, I just compare the mixed agonist and antagonist with weak agonist. Weak agonist, they weakly activate the mu opioid receptor, for example. Mixed one, they agonist at some receptor, antagonist at some receptor. Analgesic effects for the weak agonist are weaker and less potent. Mixed one, variable. The risk of respiratory depression for the weak agonist, that is lower than the full agonist, but still present. For the mixed agonist, listen very carefully, it reduces because mu receptors level, I think mu receptors are responsible for respiratory depression. So they are going to block that and reduce that side effect. So don't worry, I will give this to you so you can go through. But know the idea what mentioned by mixed agonist antagonist and know the drugs examples for that. Then we come for the mechanism of action. It is very wonderful. In your body, normally the G protein mediated transfer of or signal transduction occurs. When a ligand binds to the G protein, the 7 transmembrane protein, then the G protein get activated, adenyl cyclase act and cyclic AMP formed, and that leads to the influx of the ions and neurotransmitters are released and the signal pass. That is normal phenomenon. Here, what will happen is the opioids comes and acted or bind to kappa, mu, and delta receptors. They are going to inhibit adenyl cyclase enzyme. So cyclic AMP production is reduced. Usually calcium comes in and it will force the vesicles with the neurotransmitters to come and bind at the presynaptic membrane, and via exocytosis it released. But here what happened is there is no cyclic AMP or reduction of cyclic AMP production. So calcium cannot come in. Potassium goes out. So there is a reduction of positivity of the presynaptic membrane. So negativity is more. So action potential cannot be fast. Again, I repeat you, with opioid comes and bind with these opioid receptors. It causes inhibition of adenyl cyclase enzyme. So reduction of cyclic AMP, calcium influx is reduced, potassium goes up. The postsynaptic level, what will happen is mainly potassium goes out, so hyperpolarization of the neuron. So you are unable to excite the neuron, you are unable to pass the pain message or transmission. This is the basic mechanism of opioids. Okay? Bind to G protein coupled receptors, inhibit adenyl cyclase, reduce intracellular cyclic AMP, block voltage gated calcium channels, then inhibit substance P and glutamate release from primary afferent neurons. Because the substance P and glutamate are found in the vesicle. So when there is a less calcium, the vesicles cannot fuse and you cannot release neurotoxin. Simple. At the postsynaptic level, the potassium channels are open, potassium goes out, less positivity inside the cell membrane, so hyperpolarization. So that reduces excitability. And the few pharmacological effects, they work as analgesic and they produce analgesia, pain relief, euphoria. The euphoria is a kind of happiness, a joy. You like when you get a distinction, you got a happiness. That is euphoria. When your girlfriend says, "Okay, I will be marrying you," that's a happiness. Hopefully, it's a happiness. I assume. So then, that's a kind of euphoria. The level of happiness is stepped up. Then it helps to have a good sleep. And one of the side effects of opioid is constipation. So it helps in diarrhea. But opioid can cause respiratory depression. It reduces gastrointestinal motility and pupillary reconstruction, euphoria, dysphoria. Dysphoria is opposite to euphoria. That means you feel a kind of depression. Your mood is become low. Sedation, physical dependence. For this all action, you are supposed to know the pharmacological basis. Those are in the books. You have to find it and make a note. Okay. Then receptor types. I told you there are 5 kind of receptors, 3 major receptors, and each receptors when they get activated, they show you or they give you different pharmacological effects. Like the mu receptors, you again have subcategories mu 1, 2, 3, kappa 1, 2, like that you have subcategories. The mu1 receptor is responsible for analgesia and dependence. That means the opioids, when it comes and activate on mu1 receptor, the effect is analgesia and dependence. If it is act on mu2, that is euphoria, respiratory depression and meiosis. That means pupillary constriction and decreased digestive. I just highlighted the very important particular thing. And mu2, vasodilation. Kappa causes diuresis and dysphoria. So, if you are going to give a drug, an opioid, it acts on receptor. And if you are going to inhibit the dysphoria, what you can do is you can block kappa receptor and you can just activate mu receptor. That is a place where you have mixed agonist antagonist drug. Okay. Then delta. So this is a summary of mu1 analgesia, and we will ask this in the exam. We will ask what are the pharmacological effects of mu receptor activation, and we may ask specifically the respiratory depression is by mu2 receptor in the true false MCQ. So you should know. Okay, you should know the morphine act on mu, codeine act. Yeah, so like that you should know. And the opioids have adverse effects as well. Respiratory depression, even it occurs in normal analgesic doses, mainly via mu receptors. And if you are going further specific, mu2 and GI effect, of course, reduce GI motility, it causes constipation, and it constricts your biliary sphincter. One of the most common SEQ, repeatedly they ask is, a patient came with a biliary colic, severe pain, but you are not using morphine. You use NSAID. What is the pharmacological basis? Then you have to say biliary colic is already something blocks the biliary tract, so your gallbladder spasm to pull that. Okay, already there's a block. Sphincter of Oddi, you can remember that. That's where these comes and join the duodenum. The morphine is going to constrict that sphincter. So again, it will block the flow and it will further increase the biliary colic, or it increase the pressure inside the biliary tree and it aggravates the pain. So that is the reason why we are not giving morphine. So NSAIDs, in other hand, they don't have any problem with the sphincter of Oddi. What they did is, what they do is, they will inhibit the prostaglandin pathway. They will ease your pain. So you should know the right answer for this. You should know the pharmacological basis of that. And some opioids may cause urticaria, bronchospasm, and hypotension. So what they does is, especially morphine, codeine, and meperidine, they act on mast cells and release histamine. This is not opioid receptor modulated or mediated. They act via some other ways in the mast cells directly, and they release histamine. They cause urticaria and bronchospasm. So when you give morphine to the patient, sometimes you may see some kind of rash or urticaria found seen in the area where you give the IV. I have seen 2 or 3 cases in my 6 years or 7 years as an anesthetic. Of course, but the pethidine, it can cause urticaria, but lesser than the morphine. Some books, some places, they say pethidine also not causing urticaria, but it causes, but it is very less compared to morphine. Fentanyl, sufentanil, on the other hand, they does not produce this effect. And pupillary constriction, the opioids, they stimulate oculomotor nucleus and causes pupillary constriction. But pethidine has some anticholinergic properties. They block muscarinic receptors, and they usually they does not cause papillary constriction. Then they suppress immune function, suppress cough reflexes. You should know the pharmacological basis. Okay. And tolerance and dependence. Tolerance is increase in the dose needed to produce a given pharmacological effect. We have seen or talked, or you all learned enough of tolerance and dependence, so we just pass. Dependence, you are having, that means when you withdraw a drug or use an antagonist, you are developing few physiological effects. There are two forms, physical and psychological. And physical dependence is, we call it withdrawal symptoms that is due to the addiction. So the withdrawal symptoms you will experience in physical dependence in opioids are irritability, runny nose, weight loss, diarrhea, sweating, piloerection, and those last for 8 to 10 days. And in the dependence, you can use clonidine and ketamine as a treatment. And now we are going to look at the individual opioid drugs. First one is codeine. Codeine is found in the tablet form, syrup form. It we use for mild to moderate pain. So the basic levels of pain, and it can cause constipation and drowsiness. It available as combined with paracetamol is one of the common MCQ. In 500 milligram paracetamol, that means acetaminophen, you have 8 milligram of codeine. So this is a common MCQ, remember that. And fentanyl is one of the first short-acting opioid. It is 100 times more potent than morphine. Okay. Morphine undergoes hepatic metabolism to produce a metabolite that is more potent than morphine itself, morphine 6-glucuronide. But the fentanyl, it undergoes metabolism at the hepatic level and its metabolites are inactive. It is a longer T-half, high solubility, so it's ideal for the transdermal patch. So we may ask a question, fentanyl compared to codeine is suitable as a transdermal patch. Explain the pharmacological basis. Then you have to write on T-half, lipid solubility, and you have to say its T-half is longer than the codeine. It has a high lipid solubility, and you have to explain. See? So there are available formula, different available formulas of fentanyl, transdermal patch, lozenge, buccal tablet, sublingual tablet, even you have the nasal and sublingual spray as well. Then we come to the freely available, not freely available, mostly used analgesic drug, opioid, pethidine. It is a little different between the effects of equipotent doses of morphine on analgesia, prostate depression, and nausea. It's fine as IM. Sometimes people use IV also, but recommended one is IM. If there's an overdose, you can correct that with naloxone. That's why you may notice in the labor room, the mothers are crying with the pain. So mainly what we give is we give pethidine to reduce their pain. But if you give pethidine to mother and the baba delivered within the half an hour after you give pethidine, the baba may be drowsy because the pethidine crosses the placental barrier and it goes to the baba. So you are going to give naloxone to the who? Mother or baby. You give naloxone to who? Okay, it's up to you to give. Okay, think. And the tramadol. Tramadol is have two different type of stereoisomers, and it's act on different three pathways. One is centrally acting pathway. It relatively have a weak mu opioid receptor activity. It produces or desmethyl tramadol. Know that. This metabolite is an active mu agonist with greater receptor affinity than the tramadol. We use that tramadol for moderate to severe pain. We have oral, rectal, and parenteral preparation. Major side effect of tramadol is nausea and vomiting. If you are giving tramadol to a person, always what we are giving in the ward setup is we'll give that with an antiemetic because it has a high potency to cause nausea and vomiting. You might have noticed that in the ward, when they give tramadol, they either give domperidone or mexalone. So these are different preparation, tramadol capsules, tablets, and vials. Then comes the morphine. It works by binding mu opioid receptors, mainly central nervous system. Severe pain, we use that. Like acute or chronic pain, post-operative, post-surgical pain, cancer pains, bone cancer, they are severe pains, we give that. It can use in the myocardial infarction, in pulmonary edema as well, morphine. You should know the pharmacological basis why we give morphine in pulmonary edema. That's a common SCQ. And the side effects are respiratory depression, sedation, constipation, nausea, vomiting, and urinary retention. The long-term use of morphine can lead to tolerance, dependence, and addiction. We use morphine with caution in respiratory condition, in elderly, and the person with history of substance abuse. It's contraindicated in acute respiratory depression and paralytic ileus. You should be able to explain why it is contraindicated in paralytic ileus and acute respiratory depression. You have to give better pharmacological explanation. When I say you have to know the pharmacological basis or explanation, those can be asked in extra. Then the pharmacokinetics of morphine, the most of the opioids follow this. The morphine is slowly and erratically absorbed. IV morphine given in acute severe pain, oral given in chronic pain. Most opioids have significant first pass metabolism, and codeine is well absorbed orally. They metabolize, they undergo the hepatic metabolism, conjugate with glucuronide, undergo enterohepatic circulation. The conjugated metabolites can be more active than parent compound. I told you for the morphine, that is morphine 6-glucuronide, it's more active. For the tramadol also, the metabolite is more active. They excreted via the kidneys. So in the renal failure, you need to adjust the dose. And of course, it crosses placenta. Why is it better to avoid morphine during a childbirth? Morphine can cross placenta. Neonates, in their liver, they have lesser ability to conjugate or break it down. So the morphine has more action in neonate. It can cause respiratory depression. Pethidine, even though it can give rise to a respiratory depression, it is a safer alternative. So the morphine you can given in oral, IV, IM, all these modes you can give. The diamorphine is a heroin, highly lipid soluble, and crosses blood-brain barrier rapidly. Small values are adequate. And see other drugs and the plasma half-life. If you look at this plasma half-life of all the opioids, the short half-life opioid, it's around 3 to 4 hours. So you don't need to remember Of course, you need to remember exactly, but if you forget but remember, it's between 3 to 4 hours. Of course, for the long active, you have to remember, but this is just remember 3 to 4 hours of half-life for short-acting opioids. Naloxone is a competitive antagonist at mu, delta, kappa receptors. You can either give IV or IM. Each duration of antagonism is 20 minutes. Sometimes some opioid-induced depression lasts for more than 20 minutes, so you may have to give repeated doses. So naloxone is an antagonist you are using to reverse the respiratory depression caused by opioids. But remember, when you are reversing the effects of opioid with naloxone, you are reversing the analgesic effect also. When the respiratory depression effect is reversed, you are no more providing analgesia. So you have to find other routes, so other drugs to give analgesia without causing respiratory depression. So with that, we have come to the end of opioid receptor agonist and antagonist. Now we are going to look at the inhibitors of prostaglandin synthesis. We have seen earlier, prostaglandin is also one of the chemical mediators in pain pathway. So to reduce the pain, we are going to inhibit the production of prostaglandin. Simple as that. For the prostaglandin synthesis, there are two kinds of cyclooxygenase enzymes which helps in prostaglandin synthesis. COX-1 is constitutive, that means it usually found in your body. COX-2 is inducible, that means usually it's found in the body in a very low level. When there's a trauma, injury, the tissue damage, they induce this COX-2 and they increase the production of prostaglandin. So the main inhibitors of prostaglandin synthesis are paracetamol, other name for that is acetaminophen. It has a central action and minimal anti-inflammatory effect, and NSAIDs, non-steroidal anti-inflammatory drugs. So usually from the arachnoid acid, COX-1 and COX-2, COX-1 produced from Bexon A2, COX-2 produce prostaglandin E2 and I2. So usually thromboxane A2 does mucosal production, renal blood flow, maintain that, platelet aggregation. Prostaglandin E2 and prostaglandin I2, they are inflammation and neoplasia, tumor invasion, angiogenesis, cell proliferation, macrophage, and synovitis. So, COX-2 inducible production of prostaglandin will lead or will do these functions. COX-1 constitutive normally will do this function. If you are going to, ideally, the cytokine, carcinogen, and oncogen with the any problem, they induce COX-2. So if you are going to treat that, you have need to only block this. So if you block that only these adverse effects are gone. But there are non-selective drugs, NSAIDs, they block these two. So the good actions or housekeeping functions also getting blocked. So which is the best one? if we just think COX-2 selective inhibitors are good. But what is the problem is the COX-2 have high cardiovascular risk compared to non-selective. Okay. The NSAIDs, they are analgesic, antipyretic, they have antiplatelet activity and everything. So we are using this for the mild to moderate pain. So the action is better when you combine paracetamol with an NSAID. So avoid two NSAIDs together. You can give oral, NG, rectal, IV. Even you have IV paracetamol nowadays in the private sector. IV paracetamol. Okay. So NSAID, these are the classification. You can go through that. So non-selective NSAIDs are, that means they block COX-1 and COX-2. COX-1 is the normal housekeeping one. COX-2 is the problematic inducible one. So the non-selective NSAIDs are ibuprofen, mefenamic. Mefenamic acid is mainly we give for the menstrual pain. Diclofenac for the muscle pain. Indomethacin, of course, for that. Aspirin and methotrexate. Then COX-2 selective NSAID, celecoxib, atorvastatin. The COX-2 selective NSAIDs are, they have less GI side effects, less bleeding tendency, less renal effect. So here you should know in and out about paracetamol, diclofenac, aspirin, and if possible all the drugs. The pharmacokinetics of NSAIDs, almost complete absorption, no fast metabolism, high protein bound, so small volume of distribution. Majority are weak organic acid. They localize preferentially in the synovial tissue of inflamed joints. Adverse effect, non-selective COX inhibitors, gastric irritation because they block the COX-1 and the prostaglandin is normal. Sodium and water retention, edema and hypertension, renal interstitial nephritis. The major three side effects of NSAIDs. Commonly in the exam, they will ask for pharmacological basis. One thing is NSAID causes gastric irritation or gastric ulcer. NSAID causes renal impairment. NSAID causes bronchospasm. For those three common side effects, gastric irritation or gastric ulcers, renal impairment, and bronchospasm, you should know the pharmacological basis. The worsening of asthma. So how it causes worsening of asthma? That is again a wonderful pharmacology. So here the arachidonic acid, what we saw is here is from arachidonic acid how COX-1 and COX-2 produce substance. Here from the membrane phospholipids, arachidonic acid is formed. Via the COX pathway, they produce platelet, endothelium, and smooth muscle level, prostaglandin, prostacyclin from backbone. From lipooxygenase pathway, you produce leukotriene. When you block this, the COX, what will happen? There are more arachidonic acid molecules. So the more leukotriene produced. Leukotrienes are powerful bronchoconstrictors. Okay. So like that, you should know to write pharmacological basis. COX-2 inhibitors, they selectively inhibit cyclosinate 2, so less GI irritation, but they reduce synthesis of prostacyclin, so they prone to have vascular thrombosis and similar to other NSAIDs, they have few effects. They carry increased risk of cardiovascular events. How? Why COX-2 selective inhibitors carry increased risk of cardiovascular events? Because they reduce the synthesis of prostacyclin. In prostacyclin, you need it in the vascular luminovascular tree. So they cause us cardiovascular. Acetaminophen, paracetamol, you should know in and out about that because it's a freely available over-the-counter drug. In any shop, you can buy paracetamol. Okay. Paracetamol has an analgesic potency equivalent to aspirin, but in therapeutic doses. So now tell me, what is the strength of the paracetamol tablet available in the hospital? One tablet is 500 milligrams. So what is the maximum dose of paracetamol you can give to a person per day? You can go up to 4 grams per day if the person is healthy. That means you can give 2 paracetamol 6 hourly. So 2 paracetamol is 500 milligram into 2, 1 gram. So 6 hourly means 4 times per day. You can give 4 grams per day. The person is healthy. But if you are giving that for 3 years or 4 years in a continuous manner, the patient will get what? Renal impairment. The normal dose is 15 milligram per kg per dose. That means because in the children, you can't give large doses. So you have to calculate the dose according to their weight. The baba with, so I'm going to ask a question. A baby with 10 kilogram is coming to your clinic. And you are going to give syrup to that patient, paracetamol syrup. So can you calculate and tell me what is the volume of paracetamol syrup you are going to give that to the 10 kilogram weight baby? Calculate that. I am going to ask this from my next lecture. So you can use the paracetamol because paracetamol is always most of the time in conjugate with or we combine with other painkillers like morphine, diclofenac, usually not diclofenac with the morphine and codeine like that. Rarely because we don't usually combine two NS, right? So sometimes we prefer not to give paracetamol and NSAIDs both alone, but rather than avoiding paracetamol plus NSAID comparison or combination, we avoid aspirin and NSAID, ibuprofen and diclofenac, aspirin and diclofenac like that. We don't give, but sometimes we may give paracetamol and diclofenac. That is fine, and it depends on the consultant decision or the person who decides, the medical officer decision. Few contraindications are hypersensitivity and liver impairment. Adverse effect, just go. It's a adjuvant pain medication. So what is adjuvant pain medication? Drugs that used primarily for treating conditions other than pain, but may be analgesic in selected circumstances. Like we are using few anti-epileptics for headache and antidepressant. Like we use antidepressant, anticonvulsant, steroid, topical anesthetics, calcitonin and biphosphonate as adjuvant medication. The type of pain, acute and chronic, you know that, so just go through this. These are very basic physiology. And we have taught you. And methods of pain control, there are pharmacological and non-pharmacological methods. So non-pharmacological methods, cutaneous stimulation, therapeutic touch, massage, acupuncture, cognitive behavior therapy, CBD, CBT, biofeedback. I think all we have learned during the general pharmacology under but complementary and supplementary management, surgical management. The rules of thumb, that means when you are going to treat the pain, there are several steps you have to follow. You always start from the lowest effective dose and the simplest route. Lowest dose, simplest route. Then you gradually increase the higher dose and the different route. You start with the simplest single agent. So what is the simplest single agent you know for the pain management? Paracetamol. Paracetamol is the simplest single agent. Okay. So don't worry, the rules of thumb, I will prepare a separate 2 pages PDF and I will circulate. Okay. So this is WHO analgesia ladder. So like the ladder pattern. Mild pain, moderate pain, severe pain. So with the mild pain, we give non-opioid analgesic, acetaminophen, paracetamol, NSAID. NSAIDs are diclofenac, ibuprofen, indomethacin, aspirin, celecoxib, etocoxib. You should know the name. So these are non-opioids. We don't give opioids because opioids are powerful drugs. They have a very powerful, very adverse side effects. Then, if it is not settled with the paracetamol and NSAID, we add one opioid to that. That is moderate pain. If it is not settled with that also, of course you can change different combination of opioids and non-opioids. Still the pain is severe, you have to add adjuvants. You know what are the adjuvants in pain medication. Okay. So the adjuvant treatment you can start from initial onwards or you can start at any other step. The first paracetamol and or NSAID. So you can combine paracetamol with NSAID. No worry. But usually you don't combine two NSAIDs. Then add a weak opioid for mild to moderate pain. So what are the weak opioids? Codeine, dihydrocodeine, tramadol. Then you are changed into strong opioids. Morphine, fentanyl, methadone, oxycodone. Then you give adjuvant treatment. This is the WHO analgesic ladder. These pictures are found in the internet. You can go through that. So with that, we have come to the end of the lecture. If you have any doubt, you can always call me in the WhatsApp or text me and mail me and get clarified. And you should know in and out about the opioid, the important drug. What you can do is you can take a piece of paper, write opioids analgesics in one side, morphine, codeine, pethidine, diclofenac, aspirin, paracetamol, then the T half, bioavailability, mechanism of action, side effect like that, and the dose. You can make your own chart and have it with you because the pain management is very important in your life. When you are practicing as a doctor in the hospital, when you are practicing as a private practitioner, people come with pain. The pain can be due to various causes, but when they come with the pain, you have to treat the symptom first, that the pain first, then simultaneously you have to find the cause and treat that. So you should have a sound, very clear knowledge in analgesic, and you should know what to give, what analgesia to give, when to give, when I'm going to give that, how to give, what is the mode, is it tablet, is spray, it is syrup, or it's the injection, how you are going to give. You should know the pain is very important and analgesic is very important. Know the basics of pain, the physiology, then know the pharmacological basics of analgesic drug. That's very important. Have a nice day. So as I told you, I'm going to ask the question on next class. Have a nice day.